Welcome back to the deep dive.
Mm.
Today, we are opening up a file that feels, at first glance, incredibly niche.
Mm.
But the more you read, the more you realize it's a high-stakes thriller played out on a microscopic battlefield. We are talking about the parotid gland.
It is niche, but it's also one of the most, unforgiving areas of the human body.
Right.
And we're looking at a specific set of source materials today. A clinical guide to benign parotid tumors.
Okay.
This isn't a pop science article. This is a heavy-duty, exam-oriented audio script and study guide. It's designed for medical professionals.
So surgeons in training, people prepping for the USMLE, that kind of thing.
Exactly. People preparing for their specialist boards.
And that context is really important, I think, because the tone of this source material is intense.
It is.
It's full of warnings, never do this, always do that. And specifically, we're looking at benign disorders.
Yes, strictly benign.
We aren't talking about cancer in the traditional sense. And I think that's where the average person, tunes out. You hear benign and you think,
Okay, safe. No problem.
exactly.
And that is the fatal mistake.
Wow.
The source material makes this point repeatedly. In the head and neck, specifically in the parotid gland, benign does not mean harmless.
So benign can be a wolf in sheep's clothing.
That's a perfect way to put it. It can be incredibly dangerous,
Because of the location.
precisely because of the geography. The parotid gland isn't just a sac of saliva, it's a minefield.
A minefield.
It wraps around facial structures, and most importantly, it entangles the facial nerve.
The nerve that controls your smile, your expressions.
All of it. So the mission of this deep dive is to understand that tension. We need to navigate a world where a tumor might not kill you with metastasis, but the treatment of it.
Or the neglect of it.
Or the neglect of it, yes. It can permanently destroy your ability to smile, to close your eye, to express any emotion.
So the stakes are the human face itself.
That's it. It's about the difference between a cure and a permanent disfigurement. And often that difference comes down to, millimeters of tissue and understanding some very, very weird biology.
Okay, so let's open the clinical guide. Before we even get to the tumors themselves, the source spends a lot of time setting the board. We need to understand the terrain.
The battlefield.
Yeah. So what is the parotid gland, and why is the anatomy so terrifying for a surgeon?
Well, the parotid is the largest of the salivary glands. You've got one on each side, sitting just in front of and below your ears.
Right here.
If you clench your jaw, you can feel that big muscle, the masseter. The gland sits right over that area. Now, anatomically, the source describes the gland as having two lobes.
A superficial lobe and a deep lobe.
Right. But here's the secret. That division is totally artificial.
Artificial, so it's not two separate pieces.
No, not at all. It's one single blob of glandular tissue. The division is created by the facial nerve. The nerve exits the skull and shoots right through the middle of the gland. And that effectively slices it into a superficial layer, which is outside the nerve, and a deep layer, which is underneath the nerve.
So the nerve is the meat in the sandwich.
It's the meat, the cheese, and the reason for the surgeon's insomnia.
Right.
This nerve, the seventh cranial nerve, controls all the muscles of facial expression.
Right.
And it doesn't just run through as a single wire.
It branches out.
Massively. It branches out inside the gland into this web. It's called the pes anserinus.
Which means?
Goose's foot, because it splays out just like a goose's foot. These branches go to your forehead, your eye, your cheek, your mouth, your neck, all of it.
And the surgeon has to remove a tumor from inside this gland without nicking any of those branches.
You have to peel the gland off the nerve. The analogy is like you're peeling the zest off a fruit without breaking the skin.
Okay.
Except the fruit is a tumor, and the skin is a nerve that, if you just pinch it too hard, stops working.
And
Maybe forever.
that sets the stage perfectly. We are operating in a high-consequence zone.
Extremely high.
So let's look at the first rule the source mentions regarding the tumors themselves.
The statistics are the first comfort you can give a patient. The rule is that roughly 80% of salivary gland tumors occur in the parotid.
Okay, so they're most common there.
Right. And of those, roughly 80% are benign.
So the 80-80 rule.
Exactly. So if you find a lump in that area, the math is on your side. It is overwhelmingly likely to be benign.
Okay, so the patient finds a lump. What does it look like? The source paints a very specific picture of the clinical presentation.
This is where the deception begins.
Uh-oh.
The classic presentation is a swelling that is slow-growing and painless.
Painless.
Yes. And we need to dwell on that for a second. We are all conditioned to think that pain is the alarm bell.
Right. If it hurts, it must be bad.
Cancer hurts, infection hurts.
Yeah.
But here, the lack of pain is actually the hallmark of the benign tumor. The nerve accommodates the slow growth. It just stretches over time.
So the patient feels this lump, it doesn't hurt, the skin over it looks totally normal, and they
And
think.
it's nothing.
And that leads to delay.
Massive delay. The sources say people will walk around with these for years, sometimes decades, because it's just a nuisance.
The mass is usually described as firm but mobile. Let's clarify mobile. It's not like it's sliding around like a loose coin in your pocket.
No, not that loose. It means if you grab the mass, you can wiggle it relative to the deep structures. It's not, glued to the jawbone or the muscle underneath.
Okay.
However, the source does note a trap here. Mobility in the parotid is a bit different from, say, a lymph node. You test it by moving it horizontally and vertically. But the key takeaway is that it feels contained.
There's a golden rule in the diagnosis section that seems to override everything else. The state of the face.
The facial nerve indicator. This is absolute gospel in head and neck exams.
So what is it?
If a patient comes in with a parotid lump, no matter how big it is, if their face moves normally, they can smile symmetrically, if they can raise their eyebrows evenly.
Then it's almost certainly benign.
Almost certainly, yes.
And if they can't, if there's a droop.
If there is any weakness, any asymmetry at all, you have to assume it is cancer, malignancy, until proven otherwise.
That's a stark difference.
It is. Benign tumors push the nerve aside. They're polite. Malignant tumors invade the nerve. They are destructive. So a working nerve is your best reassurance.
Okay, so we have the landscape. Painless, slow, mobile lump, and the face is working fine. Now we meet the antagonist of our story. The source says one tumor just dominates the data.
The pleomorphic adenoma.
It sounds like a spell from Harry Potter. Pleomorphic adenoma.
It's a mouthful. But if you're a medical student and you get a question about a parotid tumor and you have no idea what the answer is,
Guess pleomorphic adenoma.
Pleomorphic adenoma, you'll probably be right. It is the most common benign tumor of the parotid, accounting for the vast majority of cases.
Let's break down the name. Pleomorphic.
Pleo means many, morph means form.
Yeah.
So many forms. And this refers to its histology, what it looks like under a microscope. The source calls it a mixed tumor.
Mixed with what?
This is where nature gets chaotic. Usually, a tumor is made of one type of cell that's gone rogue. But a pleomorphic adenoma is a jumble, a total mess. You have epithelial cells, which are the lining cells. You have myoepithelial cells, which are kind of like contractile cells.
Okay.
And they're all floating in this strange background material called stroma. And the stroma can look like cartilage.
Chondroid.
Or it can look like jelly.
Mycoid.
Exactly.
So it's a tumor that's trying to be a gland and a muscle and a piece of cartilage all at the same time.
That's a great way to think about it. It's a biological identity crisis. And that myxoid or jelly-like component is actually dangerous because it makes the tumor soft and prone to rupture if you aren't careful.
Okay, now this brings us to the most critical concept in the entire source material, the false capsule.
Yes.
The source emphasizes this so heavily it feels like they're shouting it from the rooftops.
If you take only one thing away from this deep dive, it should be the false capsule. This is the anatomical feature that dictates the entire surgical strategy.
So describe it. What does the surgeon see versus what is actually there?
Visually, when you expose the tumor in surgery, it looks like a pearl or a marble.
Okay, smooth and round.
Perfectly smooth, round, and contained. It looks like it's wrapped in a nice safe shell, a capsule.
Which invites the temptation to just pop it out.
Enucleation. That's the technical term. It looks like you could just shell it out like a pea from a pod. It's so tempting.
But
the capsule is a lie.
A lie.
It's a complete illusion. It's formed by the compressed normal gland tissue that has been squashed by the expanding tumor. It is not a true biological barrier.
And the source introduces a villainous feature here. Pseudopodia.
Pseudopodia, literally false feet.
That is disturbing.
It is. Because on a microscopic level, which the surgeon absolutely cannot see with the naked eye, the tumor has these tiny finger-like projections. Little legs that poke through the false capsule and dig into the surrounding normal tissue.
So it's not a marble, it's a potato with roots.
That is the perfect analogy. You see the potato, but you don't see the tiny little roots extending a few millimeters into the dirt all around it. And those roots are made of active tumor cells.
This sets up the surgical dilemma. If you fall for the trap, if you believe the lie of the false capsule, and you just shell out the tumor,
you are cutting right through the roots. You are leaving the tips of those pseudopodia behind in the patient's face.
And that leads to recurrence. The tumor comes back.
High rates of recurrence. And here's the nightmare scenario the source describes. Recurrent pleomorphic adenoma is not just the lump came back.
It's worse.
It's much worse. It often comes back as multinodular recurrence. Instead of one lump, you have dozens of tiny pearls, tiny new tumors scattered throughout the surgical bed.
Wow.
And it is incredibly difficult to fix the second time around because now you're dealing with scar tissue and the facial nerve is all distorted. It's a disaster.
So, because of these invisible feet, the surgery has to be more aggressive than it looks.
You cannot just remove the tumor. You have to remove the tumor plus a buffer zone of healthy tissue around it.
So let's get into the solution. The source outlines the management, or the correct surgery. It's called a superficial parodectomy.
Right. This is the gold standard. Instead of just scooping out the lump, you remove the entire superficial lobe of the parotid gland that contains the tumor.
You take the dirt with the potato.
That's it. You perform a wide excision. By taking that cuff of healthy tissue around the tumor, you ensure that all those microscopic pseudopodia are contained inside the block of tissue you remove.
So you never even see the tumor during the surgery.
You never actually see the tumor's capsule. You stay strictly in the healthy tissue plane. You respect the biology.
But wait, we just established that the facial nerve is running right through this area, like wires in a wall. If you're taking a big chunk of tissue, how do you not cut the nerve?
That is the art and the terror of parotid surgery. You don't just hack it out. The first and most important step is to locate the main trunk of the facial nerve first.
You find the main wire before you start messing with the wall.
That's it. You have to find the trunk where it exits the skull. The source alludes to landmarks, things like the tragal pointer, which is part of your ear cartilage, or the posterior belly of the digastric muscle.
So the surgeon uses these anatomical road signs.
Exactly. They use these road signs to find that white, glistening nerve trunk. Once they find it, they use a nerve stimulator to make sure the face twitches.
Confirmation.
And then they meticulously, painstakingly dissect along the nerve branches, lifting the gland off the nerve 1 millimeter at a time.
So the nerve is the floor of your surgery. You work above it.
Correct. You lift the superficial lobe up and off the nerve, taking the tumor with it. It's incredibly delicate, high-stakes work.
There's another reason the source says we can't just leave these tumors alone. We said they're benign. Why not just leave it? If the surgery is so risky, why take the chance?
Because of the time bomb effect.
A time bomb?
The source uses a very specific term, carcinoma ex pleomorphic adenoma.
Which translates to?
Cancer arising out of a pleomorphic adenoma.
So the benign tumor can become a true cancer.
Yes. If you leave a benign pleomorphic adenoma in a patient for, say, 15, 20, 30 years, the biology can change. It can transform into a highly aggressive malignancy. The risk accumulates over time.
So benign does not mean stable forever.
Not at all. It's benign now. But if you're 30 years old and you plan to live to 80, leaving that tumor in your face is a gamble with very high stakes.
And if it turns malignant?
Then it becomes painful. It invades the nerve, causing facial paralysis, and the prognosis drops significantly. It's a much deadlier situation.
So it has to come out, period.
It has to come out.
Now, while pleomorphic adenoma is the king of the exam questions, there is a runner-up. The source dedicates a whole section to Warthin's tumor.
Yes, the number 2 contender. A very different character.
And it has a completely different vibe, different profile. Who gets Warthin's tumor?
Warthin's is the tumor of the older gentleman who smokes.
That's a very, very specific profile.
It's stark. While pleomorphic is more common in women and occurs at a younger age, say 30s to 50s, Warthin's is heavily skewed towards men in their 60s and 70s.
And the smoking link is that strong.
It's undeniable. The source calls it a smoking gun for a reason. The risk is exponentially higher in smokers. It's one of the strongest associations in head and neck pathology.
Why? What does smoke do to the parotid?
It's thought that the irritants in tobacco smoke travel retrograde.
Backwards.
Backwards, yes. Up the salivary duct from the mouth and into the gland. They irritate the gland tissue. And specifically, they seem to trigger this tumor in lymph nodes that are trapped within the gland itself.
There is a visual description of Warthin's in the source that always sticks in my mind. The fluid inside it.
Yes. Crankcase oil.
That's it, motor oil.
Warthin's tumors are often cystic, which means they're hollow or fluid-filled. And if you stick a needle in one for a biopsy, you often pull out this dark brown, turbid fluid that looks exactly like used motor oil from your car.
What a description.
Like a classic exam descriptor.
And there is one other feature that makes Warthin's totally unique, the bilateral factor.
This is a huge clue, a massive giveaway. Warthin's is the only salivary tumor that commonly appears on both sides of the face.
So a lump on the left and a lump on the right.
If a patient has a lump on the left and a lump on the right, and they're a 70-year-old smoker, you almost don't need to guess. It's Warthin's. It can also be multifocal on the same side, so 2 or 3 lumps in one gland.
Very strange. There's a mention in the source about hot spots on scans. What's that about?
Right, this is a little bit of nuclear medicine. If you do a special scan, a technetium 99 meter per technetate scan, most tumors show up as cold.
Meaning they don't absorb the radioactive tracer.
Correct. But Warthin's tumor is hot. It lights up like a Christmas tree.
And why is that?
Because the cells in Warthin's tumor, they're called oncocytes, are packed, and I mean stuffed, with mitochondria.
The powerhouses of the cell.
Powerhouses. And for whatever reason, those mitochondria just love to grab that radioactive tracer. So it glows on the scan. It's a very specific exam pearl, as they say.
Moving on from the big two, the source has a short notes section for the rarer stuff. We don't need to spend an hour on these, but what should we know?
Just that they exist in the differential diagnosis, to complete the picture. You have basal cell adenoma, which looks a bit like pleomorphic, but has a different cell type.
Oh, okay.
You have oncocytoma, which is entirely made of those mitochondria-rich cells we just talked about, but without the lymphoid tissue of Warthin's.
Yeah.
And you have lipomas.
A lipoma is just fat, right? A benign fatty tumor.
Exactly. Just a benign ball of fat. It can happen anywhere, but if it happens in the parotid, it feels distinctively soft. The key is just to know that not every single lump is a pleomorphic adenoma, even if the odds say it is.
Okay, let's shift to the detective work. We have a patient, we have a lump. How do we prove what it is without cutting it out? The source is very, very strict about the order of operation.
This is critical. You cannot just freestyle the diagnosis. It's a recipe. Step 1 is ultrasound.
Why ultrasound first?
It's safe, it's non-invasive, no radiation, and it tells you the basics. Is it solid? Is it cystic? Is it inside the gland or outside? It answers those first-line questions very easily.
Okay. Step 2, FNAC.
Fine needle aspiration cytology. This is the investigation of choice.
That's a mouthful.
It is. But basically, you use a very thin needle, thinner than what you use for a blood draw, and you stick it into the lump and aspirate or suck out some cells for the pathologist to look at.
Now, I have to ask, why not a core biopsy? Usually with breast tumors or other cancers, doctors use a big needle to get a core of tissue. The source explicitly warns against this here.
Yes, and for very good reason. A core biopsy uses a large cutting needle. In the parotid, that is dangerous for 2 reasons. 1, the facial nerve. You are thrusting a cutting instrument blindly into a gland that houses the most important nerve for facial expression. You could literally paralyze the patient just trying to diagnose them.
What's reason 2?
Seeding, tumor seeding. If you punch a big hole in that false capsule with a big needle, you risk dragging tumor cells out along the needle track as you withdraw it.
You're spreading the tumor yourself.
You are effectively contaminating the field. The FNAC needle is so small and non-cutting that this risk is negligible.
So ultrasound, then FNAC. Step 3 is imaging MRI or CT, but the source says this is reserved for specific cases.
Right. You don't need a $100,000 MRI for a small, mobile, superficial lump that you can feel easily. You order the MRI if you suspect the tumor is in the deep lobe.
The part under the nerve.
The part under the nerve, exactly. Or if the tumor is enormous, or if you suspect it's cancer. But specifically for the deep lobe, the MRI helps you see what's called the iceberg effect.
Meaning you only see the tip?
Precisely. Sometimes you see a small lump in the mouth or the neck, but the MRI shows a massive tumor extending deep into the skull base. There is a specific shape mentioned, the dumbbell tumor.
A dumbbell.
Imagine the tumor grows in the deep lobe. It gets squeezed between the jawbone, the mandible, and a pointy bit of bone called the styloid process. It creates a waist.
Ah, okay.
Because it looks like a dumbbell. A big part deep inside, a narrow waist, and another big part that you can feel. You absolutely need to know that before surgery because pulling a dumbbell through a small hole is impossible.
That brings us to the biggest do not enter sign in the whole source. It screams, open biopsy is forbidden.
Absolute contraindication. Never, ever, ever cut into a parotid lump in the clinic just to see what it is.
Because you spill the beans.
You spill the tumor.
Yeah.
You violate the capsule. You create a field of contamination that makes the definitive surgery 10 times harder and increases the risk of recurrence exponentially. The rule is simple. Don't cut it unless you are prepared to remove the whole thing right then and there with a proper nerve dissection.
Diagnosis is done. We know it's likely benign. But let's play devil's advocate. The source has a section on red flags. How do we know for sure we aren't dealing with a malignancy?
We circle right back to the nerve. Facial nerve palsy is the reddest of red flags.
If the face is weak, it's cancer.
You have to assume it's cancer, 99% of the time. Other signs include pain. As we said, benign is painless. Malignancy often invades nerves, causing a deep, boring pain.
What about how it feels?
Fixation. If the mass is rock hard and feels glued to the skin or the underlying muscle, that's a bad sign. And skin involvement, if the skin over the lump is ulcerated or red or puckered.
And rapid growth?
Absolutely. Benign tumors grow over years. Cancers grow over weeks or months. It's a completely different timeline.
Now let's go into the operating room. We're doing the correct surgery, the superficial parotidectomy. We've discussed finding the nerve. But things can still go wrong. The source lists some very specific complications.
The first one is the most obvious and the most feared. Facial nerve injury. Even if you don't cut the nerve, just stretching it or handling it can cause what's called neuropraxia.
A stunned nerve.
Yes, the nerve is bruised. The face might droop for weeks or even months while the nerve recovers. But the source spends a lot of time on a very strange, very specific syndrome, Frey's syndrome.
This is my favorite part of the weird science. Gustatory sweating.
It sounds made up, isn't it?
Yeah.
Gustatory relates to taste. So sweating when you eat.
Walk us through the mechanism. How on earth does surgery cause this?
It's a classic case of crossed wires during the healing process. The term is aberrant regeneration.
Oh.
Okay, so normally the parotid gland receives signals from a nerve called the auriculotemporal nerve. These are parasympathetic signals that say, hey, we're eating, make saliva.
Simple enough.
But the skin overlying the parotid has sweat glands. Those are controlled by completely different nerves, sympathetic nerves. When you remove the parotid gland, you cut those nerve endings that used to go to the gland. You also lift the skin flap, which cuts the nerves to the sweat glands.
So you have all these raw nerve ends from the saliva system and raw nerve ends from the sweat system healing in the same area.
Exactly. And nerves are like vines. They want to grow back to something. Sometimes the nerve fibers that are supposed to drive the salivary gland grow outward and accidentally plug themselves into the sweat glands of the skin.
So the brain sends the signal that lemon is sour, pump out the saliva.
And the signal travels down the wrong track, hits the sweat glands instead of the salivary gland, and suddenly the patient has beads of sweat dripping down their temple and cheek while they eat.
That is bizarre. Is it common?
It's actually quite common, though often it's very mild. The source mentions a classic test for it, the starch iodine test.
Like the potato experiment we did in grade school.
A very similar concept.
Yeah.
You paint the patient's face with iodine and you let it dry. Then you dust it with starch powder. Then you give them a lemon wedge to chew on.
The stimulation.
The stimulation's right. If they have Frey's syndrome, they start to sweat. The sweat mixes with the starch and the iodine, and it turns a distinctive blue-black color. You can literally see these blue dots appearing on their cheek as they eat.
Can you treat it, or do they just have to carry a napkin everywhere?
Mild cases, you
Yeah.
just live with. Severe, socially disabling cases, you can actually use Botox.
Really?
You inject Botox into the skin of the cheek, and it blocks the nerve signal to the sweat glands, just like it blocks the signal to the muscles that cause wrinkles.
Fascinating. Another complication listed is salivary fistula.
This happens when the cut surface of the remaining gland, the deep lobe, continues to make saliva, but it has nowhere to go. It leaks out into the wound.
So it's just a saliva leak.
Right. It can form a collection under the skin, which is called a coelosi, or it can leak right through the stitches, which is a fistula. It's messy and annoying, but usually it's treated with pressure bandages and drugs to dry up the secretions.
We're getting to the end of the file here. The source really stresses follow-up. Why is that so important?
Recurrence. We come full circle, back to the pseudopodia.
The false feet.
If the surgeon wasn't aggressive enough, or if the tumor ruptured during removal despite their best efforts, it will come back. And recurrent tumors are much harder to cure. The risk of permanent nerve damage goes up tenfold in revision surgery, so you watch these patients very closely for years.
The source material wraps up with a rapid exam summary and a section on traps. I want to run through these because they act like a final checklist for our listeners to cement this knowledge.
Let's do it. Good idea.
Okay, trap number 1, the simple cyst.
Don't be fooled. If you see a cyst in the parotid on an ultrasound, don't assume it's just a benign fluid collection. Pleomorphic adenomas can degenerate and become cystic. Warthin's is cystic. And some cancers, like mucoepidermoid carcinoma, can be cystic. A cyst is a tumor until proven otherwise.
Trap number 2,
Yeah.
enucleation is acceptable for small tumors.
False. Never. Size does not matter. The pseudopodia are still there. Wide excision is the only way. Enucleation is malpractice.
Trap number 3, FNAC spreads the tumor.
False. That's a myth. Large bore core needles can spread tumor. Fine needles, like for FNAC, do not have a significant risk. FNAC is safe, and it is the recommended procedure.
Okay, now let's do the 10-point recap. I'll tee them up, you knock them down.
Ready?
Point 1, the vast majority of parotid masses are.
Benign, and specifically pleomorphic adenoma.
Point 2, the symptoms are deceptively.
Painless and slow growing.
Point 3, the crucial physical sign of benignity is.
An intact working facial nerve, no weakness.
Point 4, pleomorphic adenoma is dangerous because of its.
False capsule and its microscopic pseudopodia.
Point 5, because of those pseudopodia, the correct surgery must be.
Superficial parotidectomy, which is a wide excision, not enucleation.
Point 6, if you leave a pleomorphic adenoma alone for 20 years, it risks.
Malignant transformation, becoming a carcinoma ex pleomorphic adenoma.
Point 7, the older male smoker with bilateral lumps likely has.
Worthen's tumor.
Point 8, the hot spot on a technetium-99 scan is.
Worthen's tumor because of all the mitochondria.
Point 9, the diagnostic sequence is.
Ultrasound, then FNAC, then an MRI, only if you suspect it's deep, and absolutely NO open biopsy.
And point 10, sweating while eating after surgery is called.
Fraze syndrome.
It's amazing when you boil it down like that. It's such a logical chain of cause and effect.
That's what makes this source material so good. It builds a case. It's not just a list of random facts. It's a story about anatomy dictating destiny.
So let's synthesize this. We've spent the hour deep diving into a gland most people never think about until it swells up. What is the big takeaway for you?
For me, it's about respect for the word benign. In medicine, and maybe in life, we label things as good or bad, benign or malignant.
Right, black and white.
But this deep dive shows that benign is complex. It has roots, it has behavior, it requires precision. If you treat a benign problem with a casual attitude, if you just scoop it out, you create a malignant situation, a recurrent mess.
It's the paradox of the parotid. The tumor itself won't kill you, but the wrong move will ruin your face.
Exactly. It highlights the surgeon's burden.
Yeah.
It's not enough to be good with your hands. You have to understand the biology of what you are cutting. You have to visualize those invisible feet.
I keep thinking about that patient profile, the person with the painless lump who waits 3 years because it doesn't hurt.
And that's the public health message, isn't it? Pain is not a reliable indicator of severity in the head and neck. If you have a lump, any lump, get it checked. The best time to remove a parotid tumor is when it's small and the nerve is far, far away from the edges.
And for the budding surgeons listening,
Yeah.
don't trust the capsule.
Never, ever trust the capsule. It's a lie.
I want to leave our listeners with a final thought to mull over. We've talked about the false capsule, a barrier that looks real but isn't. And we've talked about aberrant regeneration nerves trying to heal but connecting to the wrong things, making you sweat when you should salivate. It strikes me that the body is incredibly resilient, but it's also easily confused. It tries to wall off the tumor, but it fails. It tries to regrow its nerves, but it crosses the wires. It makes you realize that healing isn't always perfect. Sometimes the body's own attempt to fix itself creates a new problem that requires our understanding to manage.
That's a profound way to look at it. We are biological machines that sometimes improvise, and not always for the best.
A little humility in the face of biology goes a long way.
Absolutely.
That's it for this deep dive into the parotid gland. We hope you never have to use this knowledge personally, but if you do, now you know about the potato and the roots. Thanks for listening.
Stay curious.